Now that we've talked about the epidermis, let's move down into the dermis. Remember, the dermis is just deep to the epidermis, just below it. It's anywhere from about 0.5 millimeter to 3 millimeters thick, and it's made out of proper connective tissue. There's lots of collagen fibers and elastic fibers and reticular fibers. There are mobile white blood cells called dendritic cells that move around within the dermis. There's blood vessels and sweat glands and sebaceous glands and hair follicles and nerve endings all over the place. There's two layers. There's a papillary region and a deeper reticular layer. The papillary region is superficial. It's just barely deep to the epidermis, and it contains some areolar connective tissue. And there's little dermal papillae. These are the little mounds that kind of push up into the epidermis, and the epidermis and the dermis kind of fit together like egg crate foam. So if you take a piece of egg crate foam and cut it in half, take one of the sides and flip it upside down, you could put it into the other one, wiggle it a little bit, and then they'll fit together kind of like interlocking teeth. So that's what the dermis and epidermis do. All those little bumps are called papillae, and then that it helps the dermis and the epidermis adhere to each other. It gives a lot more surface area. Interestingly enough, the dermis and the epidermis start off as two different kinds of embryologic tissue. The reticular layer of the dermis is where all the fun things are at, and it has a lot of dense, irregular connective tissue to withstand stress and shear from different directions. Lots of collagen fibers all over the place. So here you can see the dermal papillae here, all these little bumps. It's a papilla. And then within the papillae, in the dermis, we've got little loops of capillary. We've got little nerve endings that kind of push up into there sometimes. And that's because we want to get the blood supply as close as we possibly can to the epidermis. Remember, the epidermis is made out of epithelial tissue, which is avascular. And so we can't draw blood directly into it, but we can get it as close as we possibly can. And so all these little dermal papillae are going to have these little capillaries in them. So looking around inside of the reticular layer, you can see there's a big old hair shaft here. If we follow it down, all of the surrounding tissue is called a hair follicle. Next to the hair follicle, associated with it, is this thing that's a sebaceous gland. There's the other side. These little coiled tubes here are going to be eccrine sweat glands. This lemon-looking thing here is a Paxinian corpuscle. It's a type of sensory ending for deeper pressure. And we've got arteries and veins woven all through that dermal layer. Now, when we look at the dermis, the bundles of collagen tend to follow certain pathways and patterns as they're laid down, and we call these cleavage lines. This allows the body to bend and move in certain ways and be strong and resilient in other ways, but not bend so very much. For example, if you look at your knee has to bend across the front of the knee. The anterior side has to stretch quite a bit. And so collagen really doesn't stretch very well. So it doesn't make any sense to run collagen longitudinally along your leg across the top of your kneecap. That would prevent your leg from bending very easily. We still want a lot of collagen there. We want the strength. So instead of running it vertically, we're going to run it horizontally in what we would call a transverse pattern, side to side across the top of the kneecap. That still gives us a lot of strength, but it also allows our knee to bend. And it's important to understand these lines of cleavage and the tension lines because they're an important consideration for surgery. So you can see here, as I mentioned with the knees, collagen fibers are all laid down transversely across the knee, and that allows us to flex the knee and not have to stretch any of the collagen. So I'm not going to ask you specifically which direction cleavage lines run. You just need to kind of know what they are. If we do an incision, surgical incision, between the lines, that's going to heal a lot more quickly than if you just cut across those cleavage lines and destroy all those little collagen bundles. Tattoos are markings that are placed upon the body. Temporary tattoos are ink that is placed on the epidermis. Because the epidermis is constantly sloughing off, they don't last very long. If you pay more than, a box of Cracker Jacks for your tattoo, they're going to take a needle and push the dye underneath the epidermis down into the dermis, and then it becomes a permanent part of that dermal layer. It's really, really hard to remove the tattoo because it's, down in the middle of your tissues. You can use lasers to kind of change some of the pigment. Sometimes they'll try bleach, and apparently there's newer inks now that you can get that allow for the removal. Finally, the subcutaneous layer of the skin is a little bit of hypodermis and a little bit of fascia. It's not really part of the integument. It just kind of sits there and helps to insulate the body from temperature changes, pads and protects the body, and that's really about it. We do subcutaneous injections. There's an extensive vascular network, and so by putting drugs or medications into the subcutaneous layer, that allows us to rapidly disperse the drugs or the medication. The subcutaneous layer is thicker in females. It accumulates primarily in the breasts, the buttocks, the hips, and the thighs. It tends to be thinner in men, with it accumulating primarily in the neck, the upper arms, the abdomen, and low back. So here is the epidermis, the dermis, and the hypodermis. You can see a little bit of, we don't really call that an epidermal papilla. Instead, we're going to call these the dermal papillae, and then the epidermis would just kind of fit down inside in that little valley there. So the integument as a whole is a physical barrier, as I mentioned. It protects us from injury, protects us from trauma. It's also really resistant to chemicals and toxins and microbes and temperature changes, and it helps to protect us from solar radiation. Part of that protection is because we've got dead tissue facing the outside world. If you knock some of your cells off, who cares? You're going to make more. It's not a big deal. The integument is really important to prevent water loss or gain. The epidermis, it's water resistant. It's not waterproof. You can lose water by sweat. You can lose it through transpiration. Fluids can very slowly penetrate through the epidermis. It can evaporate in air. When you burn yourself, then you've destroyed part of the integument, and it can no longer function in that area to help prevent the loss of water, and so water will start escaping that area, and the risk for dehydration goes up markedly. Also, because it's no longer an intact barrier, you're also at a much higher risk of infection. One of the cool things that the integument does is it helps to regulate vitamin D, cholecalciferol absorption. So there's a precursor used in the keratinocytes, and when they are exposed to ultraviolet radiation, then that you're going to make more vitamin D, and vitamin D is really important to absorb calcium in the intestines. If you're not getting outside very much and getting ultraviolet radiation, then you're not getting enough vitamin D. The integument also does some secretion. We're going to get rid of waste products such as extra water, salt, urea, and we can adjust the amounts that we're putting out in order to maintain homeostasis. We also make a kind of fatty, oily secretion called sebum, and this is it's produced by these sebaceous glands, typically around hair follicles, and that helps to not only make our integument water resistant, but it also has some antibacterial and antifungal properties to it. If you know somebody who's gone a few days without washing their hair, the sebum tends to wick up the hair shaft and make the hair look greasy or oily. The skin can also absorb things. A few chemicals and drugs can be absorbed through the skin. It is selectively permeable, though. Some materials pass through, others really don't go through. Oil-soluble drugs or fat-soluble drugs can be delivered via adhesive patches, and they'll slowly penetrate the epidermis and be absorbed by blood vessels. Now you'll notice that at no point in there have I talked about breathing through the skin. For some reason, there was a bizarre rumor started years ago that you need to breathe through your skin, and that is completely false. You breathe with your lungs and through your nose. There was a James Bond film called Goldfinger where, in the film anyhow, a woman was killed, painted gold, and put on James Bond's bed. And there's a very iconic scene where she's laying there on the bed, painted gold. And somehow the rumor got started that the actress died because when they painted her, her skin couldn't breathe and she suffocated. In reality, that did not happen. The actress, went on and was in other films after that, so she clearly was alive. Um, and you don't breathe through your skin. MythBusters also did an interesting episode on it where they painted Jamie Heineman in gold latex. They did have to stop partway through because one of the things the skin does do is temperature regulation. And by preventing sweat from escaping the skin, um, Jamie's internal core temperature wasn't able to be regulated correctly, and he started feeling very ill. So the integument has other functions, such as the immune function. We've got the dendritic cells inside of the epidermis. As I mentioned, we do temperature regulation, and the skin is a massive sensory organ. It's got extensive nerve endings through it, distribution of nerve fibers. There's all kinds of stimuli that we pick up: touch and temperature and vibration and pressure and pain. Not a fun sensation, but it is important.